Hello, and thank you for joining. Before we start the webinar, I would like to acknowledge that I'm hosting from the traditional owners of the lands of the Hornsby Shire, the Darung and Gurunung peoples, who have lived in the region between 15,000 to 20,000 years before the European settlers arrived in 1788. I acknowledge the traditional custodians of the various lands on which we all meet today, and the Aboriginal and Torres Strait Islander people participating in this meeting. We pay respect to those elders, both past and present. Hi, my name is Kwabena Answer, and I'm the Head of Communities and Strategy at the LOTE Agency, Australia's leading multicultural research and communications agency. We get to host these webinars so that we and our great clients and guests can share their experiences and learnings with you. Today's guests are Dr. Carlene Wilson and Dr. Eva Yuen. Dr. Carlene Wilson is the Professor of Psycho-Oncology at the Olivia Newton-John Cancer Wellness and Research Centre in Melbourne and Professor of Behavioural Oncology at the University of Melbourne at Melbourne School of Population and Global Health. Both positions involve understanding how cancer shapes the lives of those diagnosed and the peoples who care for them. The challenge that cancer presents is not just a medical one. It presents immense psychological, emotional, and practical barriers to normal life that can persist. Dr. Wilson is interested in documenting these challenges in order to develop responsive health systems. She is particularly keen to give voice to those with cancer who may go unheard, including those from culturally and linguistically diverse backgrounds. So welcome, Dr. Wilson. Dr. Eva Yuen, she is a Dean's Health Research Fellow with the Institute of Health Transformation and the Quality and Patient Safety Research at the Monash Health Partnership at Deakin University. She is also an adjunct research fellow at the Trobe University and holds an honorary appointment with the Psycho-Oncology Research Unit at the Austin Health's Olivia Newton-John Cancer Wellness and Research Centre. Her research interests are focused on improving health outcomes for people with cancer and their caregivers, optimising supportive care, and promoting health literacy across chronic disease and culturally and linguistically diverse populations. As part of her PhD project, she developed the first conceptual model and measurement tool of cancer caregiver health literacy. Her current work focuses on understanding the impact of caregiver health literacy on care recipients and caregiver health outcomes. So welcome, Dr. Yuen. Today, both Dr. Wilson and Dr. Yuen will present the results of a study undertaken by researchers from the Olivia Newton-John Cancer Wellness and Research Centre, La Trobe University and Deakin University. The study was jointly funded by Cancer Australia and these organisations and included input from the LOTE Agency. I'm sure we all understand that a cancer diagnosis presents a profound physical, practical, psychological and emotional challenge to patients, survivors and their family. This challenge is likely to be even more difficult for those from non-English speaking backgrounds, and where cultural differences affects the way cancer is perceived and expectations about treatments and recovery. And that is why this research is so important. Please note that this webinar will be available on demand. So the recording will be sent to registrants in the coming days. So without further ado, I'd like to hand over to Dr. Wilson and Dr. Yuen to present the results of the study. And just so everyone knows, there'll be time for questions at the end with Professor Vicky joining us as part of our Q&A session. So thank you, Doctor. You're just on mute, Doctor.
Sorry about that. Thanks everyone again for joining us today, and thanks Barbara for your kind introduction. The project I'm going to talk about today is a joint project, as Barbara indicated, between Austin Health, particularly the LNJ Centre, Deakin University, La Trobe and Monash Health. And it is funded by Cancer Australia, and the aim is really to try and understand the needs of culturally and linguistically diverse cancer patients and their carers in order for us to improve our supportive care services. And it originates from a commitment to improving services within Austin Health Living Newton John Cancer Centre. Okay, so I'll start with a brief summary of what we're going to be talking about today. I'll start first and present some scene setting for the audience, and then I'll be looking at a couple of studies or streams of research that we've undertaken at Austin Health, but also through LOTE, and some survey work and some interview work. And this will be followed by Eva talking about the supportive care needs of carers. So let's start by setting the scene. Cancer is prevalent around the world, but it's particularly prevalent in Australia. In fact, we have the highest prevalence rates in the world. This reflects high prevalence for skin cancer, bowel cancer, breast and prostate, but across the board, Australia and then New Zealand have the highest prevalence. Cancer itself has significant physical challenges, but also has significant psychological and emotional challenges. So we have distress experience following a diagnosis, and then ongoing anxiety and depression. So we know that nearly 30% of people with cancer will experience depression, and 50% or more will experience anxiety. And part of this is associated with the unmet information and psychological support needs. So everyone knows, if you think about it, what a cancer diagnosis would mean to them, what a shock, what a horror, what uncertainty. And so information and psychological support needs are likely to be high. Moreover, when these needs are not met, this is associated with reduced physical and mental health outcomes, including reduced quality of life and poorer overall well-being. And lastly, existing research suggests that CALD cancer patients have reported higher psychological distress and worse quality of life than English-speaking Australian-born counterparts. So this suggests this is an area where we really need to drill down to work out what's going on for CALD cancer patients. So how prevalent, how much of our community is made up of CALD cancer patients? So we know that about 25% of the Australian population were born overseas, and about almost a half, 43%, had at least one parent born overseas. Importantly, 23% of people speak a language other than English at home. This is commonly Mandarin, Arabic, Cantonese or Greek, and 2% don't speak English at all. We also know that CALD communities have a lot of participation in the widely available prevention and screening programs that we have in Australia. And because they don't participate at the same levels, they are more likely to be diagnosed with cancer at a later stage. And this has significant implications for both prognosis and their treatment experience. So importantly, who we are and where we come from influences how we view our health. And importantly, it influences how we understand and respond to cancer. So the Cancer Australia study was really about looking at what's happening currently at Austin Health and as a representative of the broader hospital system, and what can we do to improve supportive care services for CALD communities. We know that health professionals struggle to identify distress in cancer patients on treatment and even in survivors. But we want to know to what extent, and even though this is core to the delivery of supportive care service. So what we talked about what we looked at in this study was the extent to which distress, a simple measure of distress, was used among both CALD and non-CALD patients attending Austin. And we achieved this through a record review of all patients attending cancer-specific treatment units. The distress thermometer is a one-item question where the person records or indicates their degree of distress they've experienced in the preceding week. It's in the shape of a thermometer, 0 being no distress, 10 being maximum distress. And we looked at the extent to which these data were recorded at Austin. We found that in our audit of about 7,000 patients, about 12% of whom were CALD, just over half, both CALD and non-CALD patients, had a distress screen within their file. And these distress screens are associated then with referral to supportive care services, depending upon what particular problem is associated with that distress. When we look at that referral, we found that reported uptake of referral services was about 75%, but this seemingly good uptake rate really reflects referrals to allied health and medical services for physical problems, so massage, acupuncture, those sorts of things, rather than necessarily other forms of supportive care. When we look at referrals for emotional problems, however, only 55% of those who had an elevated distress, that is scored above 4 on the stress thermometer, took up the offer. 55% did not take up the offer regardless of CALD status. So for both groups, both CALD and non-CALD, there's a reluctance to follow through on dealing with referrals for emotional and psychological problems. We wanted to follow this up by looking at, so what happens within the distress screening tool, and it's a simple tool to use. And what we found was that CALD patients were much less likely to fill the form in themselves, and they were more likely to have a family member do it. This is by comparison to non-CALD patients, even though the distress in the groups were similar, but distress scores for CALD and non-CALD were higher when the family member completed the form. So family members either overestimate or are super sensitive to perceived distress in the patient. And these differences in how the form was completed highlight the need for us to look at further improvements to ensure that CALD patients are actively involved in identifying their own needs and therefore their own care. We then went on to do a survey where we collected data from 3 CALD groups. These are the ones that are the highest attendees at Austin Health. These are Arabic, Chinese and Greek language speakers. And these were recruited by LOTE, and they received a survey in either English or in their first language, either online or in paper. And this survey included a number of measures, but today we're only going to talk about the supportive care needs survey, which really talks about what are the needs of these particular groups in terms of supportive care. I'm just going to summarise the data on the next slide. Don't get too carried away with reading every line. It's quite a dense slide, but what we've got here are the top 4 unmet supportive care needs in the last month for these 3 particular language groups. We've got each column is a language group. We've got Chinese, the Arabic speaking and the Greek speaking. And I'll start with the observation that the highest levels of unmet need were by and far reported by those from the Chinese speaking background. So you can see that for the top need, 81% reported this particular unmet need, that is help with feeling unwell. And even down to the 4th highest unmet need for this group was still at 75%. Whereas in the other groups, while there were still high levels of unmet need indicated by approximately half of the people in the sample for any one need, they were significantly less than for the Chinese speaking. Now, if we look at the different sorts of needs, if we focus just on the green ones in the first instance, you can see that being informed, having information that's relevant to the specific needs of the specific individual is critical. All 4 columns have green text indicating that being informed for different reasons, for different aspects of their care was important. Then if we look at the blue, we can see here, this is only in the Chinese speaking and Greek speaking, that so there's a strong need, particularly for the Chinese speaking, for help with physical symptoms. So for the Chinese, for feeling unwell and for pain. And note, these people are up to 3 years post treatment. So these aren't people in the midst of treatment, but they're still having ongoing physical needs. And obviously within the Greek speaking, we've got lack of energy and tiredness. Then if we look at the pink, we've got here emotional and psychological support needs. So here we've got uncertainty, depression, worry, loss of control, anxiety, trying to maintain a positive outlook, having fear and uncertainty. So all of these emotions and psychological challenges that we've already talked about are clearly demonstrated across the 3 groups as among their top unmet supportive care needs. And lastly, within the last 2 columns, you'll see that having a better communication with staff was seen as very important. So, for example, one member of the hospital staff with whom you can talk is important, and the staff acknowledging and showing sensitivity is also identified as important. So again, information and psychological support needs. I then went on to try and summarise this information in these thought bubbles, and these are just my summaries of the results. So remember, the Chinese group had the highest level of unmet supported care needs, or indicated a high level of unmet supported care needs, and I summarised them in this way. I need help to feel well and with my pain. I don't feel informed and I'm worried about my future. I'm depressed and things are out of my control. For the Arabic speaking participants, I want to know how to help myself to be well. I'm worried. I try to keep a positive outlook, but I need someone at the hospital to talk to so I can stay informed. And lastly, for the Greek speaking patient, I want to be informed about my treatment and help with my tiredness. I need the staff to empathise. I try to keep a positive outlook, but I'm scared about the future. I want information and choice. And so there's a lot of consistency there that you can see that's coming through. And so we want to do a deeper dive on the experiences for these patients and for the staff in working with CALD communities. So we did some interviews, and the first interviews I'm going to just briefly summarise are those that we did with 6 wellness staff at Austin Health within the ONJ Centre. And here, the main challenges for the staff was really a communication challenge. So it's coming from both directions, both the staff and the patients, who are indicating that that communication is the key challenge that's facing both groups. So, for example, a supported care nurse working talking about an Arabic-speaking patient indicated that having her husband as an interpreter was a bit of a concern because she was worried about whether the husband was talking about what was really important to the wife or perhaps reflecting his own concerns. A psychologist indicated 2 real communication challenges. First, around health literacy, so that being confident that the patient they were talking to really understood their diagnosis and trying to help them with that understanding, and related to that, trying to help them with their reactions to that diagnosis. So helping with acceptance work and strategies and managing unpleasant thoughts and emotions. And you can see that communication here would be key to helping someone with that challenge. And then we did about 12 interviews with CALD cancer patients. And primarily what we've got here is Chinese and Arabic speaking patients who we talked to about what happened during their cancer diagnosis and treatment, and what were the main challenges that they experienced. And here are the themes that emerged. First of all, it's a challenge of relying on others. So we've got a Chinese female patient here who said, I wasn't informed about much detail at all because I was accompanied by a friend. So there was a reliance on the friend. And the question was, did the friend act as an interpreter for you? No. And the response was, she's not an interpreter at all. She's just helping me. And that's why she probably wasn't sure. She didn't understand much about the medical information. So this reliance on others, where the others themselves may not necessarily have the level of expertise or even communication competence.
Oh, this is bad. Now, what is that?
I think that, sorry, is a challenge. Okay, so we go on to the need for more information and emotional support at diagnosis. That was another key theme, and I think that's come through with the survey as well. So I think it'd be more helpful if I can sit down with someone, information about how we'll be dealing with the cancer and the emotions, and they may try to calm me a bit and just give me a clear way of going forward to treat the cancer. So a sense of slowing down, getting the information, getting clear communication that touches on emotions as well as the treatment options. The Arabic speaking female interestingly says, I couldn't tell anyone in my family first because I want to be sure. I don't want to tell anyone now because I don't want the family to be, everyone will come and leave their job. So wanting to protect the family from the diagnosis rather than actually engage the family. And then when we look at the need for clarity and spiritual need during the treatment, there seems to be a need for clarity, but also interestingly some need for spiritual support, which may or may not be readily available within the context of the treatment environment. So the Chinese female says, in the oncology department, each time there is a review or treatment, I always have an interpreter. It really helps. So I feel clear about my symptoms, about my cancer. Again, emphasising that the role of a formal interpreter in providing clarity around what's going to happen, particularly with the treatment, so that information need. But then speaking about more the emotional need, because I'm religious, I'm praying a lot, I'm asking God to help every time. And so this depends upon God and recognizing that people aren't necessarily seeing their outcome as dependent upon their own control, but being out of their control and having to get help in dealing with that loss of control. Then at discharge, the ongoing needs are the move from reliance on the professional to the carer, or taking after you, or looking after yourself. And as the Chinese woman said, the doctor's going to be so busy, they don't have too much time to stay with you. But for example, having some help with her sit down with us and go through the details, that would be helpful. Her experience was that she was just given information and said, take this home and read it. And even if it was in Mandarin or Cantonese, that may not necessarily have addressed her information needs. And for the Arabic speaking woman, one of the Arabic speaking women said for herself, emotional support. But she wanted that not just from health professionals, but more particularly from the family members themselves. And as we come to wrap up these results, I'd like to talk about what the patient's thoughts were on improvements that were needed. And as we've indicated, interpreting services are key. They need to be strengthened. This particular woman had no communication. She didn't have someone there to help her with the interpreting. For her whole period while being treated, she didn't know anything, so she herself wouldn't communicate. So because she couldn't understand, she didn't reach out to try and indicate what her own needs were. And another Chinese female said, if I could have more details for the Chinese community, maybe more in Chinese language, then she would have the full information. So in language, interpreter services, all critical. So the two main things, according to an Arabic speaking female, that would lead to improved services are good access to interpreting services, but also access to psychology counselling. And I should say, particularly at diagnosis, and this is available, but it's getting people to access those resources that is really critical. And I want to conclude my part of the presentation with the brief observation that it is harder to be a carer than to be a patient. And this particular woman who was interviewed was Arabic speaking, and she had been earlier a patient, I think breast cancer, and then subsequently her husband, who was also Arabic speaking, was diagnosed with a terminal cancer. And she made the interesting observation that she was much more in control when she had the cancer. She knew what she had to do. I know what I'm going through, but having to have enough control of what somebody else is feeling or how they're coping and managing, that was much more challenging. It's like we always forget, we think we focus on the family and on the patient, and we forget the family. And as she said, as she had 2 young children, it's the family. And again, the whole situation, somebody dying. The people who are left behind are the ones that matter, right? And for me, it was like, I just need someone to support the kids while I looked after him. So the challenges of the carer cannot be underemphasized. So I'm going to stop sharing, and I think Eva will take over from here. And thank you very much.
Thanks, Carlene. Thanks, Kwabana. I'm just going to share my screen. Okay, hello everyone. Today I'm going to talk briefly about the important role of caregivers for people with cancer from core communities. And across various populations, family members and friends, who are often referred to as informal caregivers or carers, we know that they play a pivotal role in the diagnosis, treatment and management of cancer for people who've been diagnosed. And so these family members and friends can play an important role in driving people to and from hospital, asking questions during appointments, communicating with doctors, as well as making key decisions about treatment. And we also know that family members and friends are critical in the home care setting, so managing symptoms and side effects. They can also provide practical care, medical care, as well as provide social, emotional, and psychological support for people who are diagnosed with cancer. And so whilst this caregiving role can be quite rewarding for people, we also know that it can be quite stressful, demanding and burdensome. And this can also impact negatively on the caregivers own health and well-being. And this is because these caregiving roles, whilst very important, is often managed alongside existing responsibilities, such as managing work, family, as well as the household. And for caregivers of people from CALD communities, they can take on even greater responsibilities, especially if the patient has English as a second language. And so these caregivers often take on the role of interpreting and communicating between providers and patients, and they can take on the role of managing all of the patient's appointments. And so we know for people from CALD communities, there can be cultural beliefs, attitudes, as well as taboos around a cancer diagnosis, as well as around death and dying. And this can all impact on people's understanding and preferences about how they manage a cancer diagnosis and the treatment. And so we know for people from CALD communities, there can sometimes be stigma associated with the cancer diagnosis as well. And so this stigma around cancer can also impact on how people manage and talk about the disease. So people might not want to talk about the diagnosis with their extended family or with their friends. And this can lead to barriers with being able to seek formal or informal supports. So not talking about the diagnosis with their family members and friends can also impact people's own health and well-being if they don't have people that they can trust and support to talk to and have support for themselves. And so we know from the work that we've done that it's important to focus on both patient and caregiver supportive care needs. However, at the minute, there aren't very many studies that have focused on the specific needs of caregivers of people from CALD communities. And so we conducted some work with these caregivers, and we interviewed both Chinese and Arabic caregivers, and we also conducted a survey study. And so we'll be talking briefly about these findings today. And so, as I mentioned, we're conducting interviews with caregivers of people from Arabic and Chinese communities, and this study is ongoing. And this work is being conducted by our Master of Clinical Psychology student, Megan Hale. So thank you for her work with this. And in looking at some of the early findings, we can see some themes emerging across these interviews and when people are talking about their experiences and their health service needs. And so these themes that have emerged include caregiving as an individual responsibility. And so these caregivers have a sense of not wanting to burden other people. And there's also a theme around challenges with understanding and accessing health information for caregivers. And there's also different perspectives about supportive care and supportive care services that are available for caregivers. And there was also, and I'll talk briefly about the improvements that are needed and the power of advocacy for caregivers and people from CALD communities. And so in this first theme, there was a real focus for caregivers, and this came across quite a few interviews, about caregiving as an individual responsibility and really not wanting to burden others with their stress or their worry in relation to caregiving. And so you could see this in some of the quotes that we've taken out during from the interviews with caregivers. So for example, with the Chinese male caregiver who was looking after his mother with kidney cancer, he really talked about how he didn't want to share his caregiving role or any of the burden with his wife, and that he didn't think it was their business, and he didn't really want to bother his immediate family or extended family about what was going on with his caregiving role. And so for a Chinese female who was looking after her mother with head and neck cancer, she was quite reluctant to talk about her situation with her friends. And so she wasn't sharing with her social circle. And she spoke about not being very open to talk about the situation with her friends. And the sense, there was also a sense of stoicism. So thinking that the belief that you have to go through this situation yourself and that no one else could really help you. However, this caregiver did mention that when she did speak about her experiences with her friends and her social network, that she did actually feel a lot better and that she felt more positive about the situation. She had a better outlook. And for another Chinese male caregiver who was looking after his sister with cervical cancer, he really spoke about not talking with his friends or family about the diagnosis or treatment. And for them, they actively avoided talking about the cancer. And this was because there was a sense of stigma around. So it would be bad luck or bad fortune if they spoke about it. And if they talked about the cancer, then it would, there's a potential for it to return. So as part of this broader theme, you can see these, there's a stigma associated with the cancer diagnosis, but also a sense of stoicism for caregivers about wanting to sort of keep this role to themselves and having to manage on their own. And so then going to the next theme, and this included challenges with understanding and accessing health information. And so for a number of caregivers, they had a lot of difficulty with finding the information that they needed about the diagnosis and about the treatment. And you can see in this first quote, there was some, the male caregiver was saying that they just couldn't understand the information, but they also didn't want to ask what the medical terms meant. And so they didn't want to bother the doctors with their questions. And this was similar to another female caregiver who had mentioned that she just didn't know where to ask. She didn't know, she just did the best that she could. By contrast, there was another caregiver who was quite resourceful. So she didn't have the information that she needed, but wanted more support. So she went and sought out her GP, who spoke the same mother language as her. And so she found it easier to understand what the technical terms were without having to translate all of that information. So it was about finding resources and supports that were able to provide information in ways that they could understand. And then in looking at this theme about perspectives about supportive care. So when talking with caregivers and asking them, well, how can health services or clinicians better support them with their supportive care needs? A lot of the caregivers found it very difficult to talk about themselves, and they referred a lot to their patient. And so when you talk about supportive care services for the caregiver, one male caregiver mentioned, well, no, he felt that it was something that they had to manage on their own, especially with the emotional aspects of caregiving, and that they thought that really the hospital or health services couldn't really provide them with much because it's something that you have to go through on your own. By contrast, a female caregiver mentioned that she did access psychological services, and this is because she spoke with her daughter, and her daughter had mentioned to her that it's normal to seek out psychological services. And after 4 sessions, she had mentioned that she did feel better about the situation. She had more perspective, and she was able to sort of manage her experiences going forward. And so talking about the last theme and looking at and talking about improvements needed as well as the power of advocacy. And this is these are quotes from a female Arabic speaking caregiver. And she really spoke about health providers being sensitive to culture and how people might want things done or how they might want information to be presented. And so she felt that it was important for caregivers to have that cultural sensitivity when they were speaking with her and her husband, but also that I think there was some frustrations that there was some important news that was provided to her, provided to the patient, and she wasn't there in the room, but the doctor just sort of went ahead and gave that news. And so I think it was just more about including the family in that sort of decision making and sharing of the news. But she also mentioned there were very positive aspects with their healthcare, and they were treated exceptionally well because there were advocates, so advocating on his behalf and making sure that the supports and interpreters were available at the time. And so we also wanted to get a sense of what types of unmet supportive care needs that caregivers might have. And so we also conducted a survey study to really identify these unmet supportive care needs for caregivers. And so we invited caregivers from 3 different CALD communities, and these included Arabic, Chinese, as well as Vietnamese, because these are in the top 5 most widely spoken languages in Australia. And we also included an English only Anglo-Saxon population. And we recruited caregivers through Prolific, which is an online market research platform, and caregivers were invited to complete the surveys in English. And people from Australia, the United States, New Zealand, the UK and Canada were also invited to participate, well, caregivers who lived in these areas because of the similar health services that are available. And so caregivers completed the supportive care needs survey for partners and caregivers. So it's a 45-item survey that looks at the unmet needs for family members and friends across 4 domains. And so these domains include healthcare service needs, psychological and emotional needs, work and social needs, as well as information needs. And so in the next few slides, I'll present some preliminary analyses of what we found. And so looking across these 4 domains, I'll just provide brief examples of these supportive care need domains. And so for the healthcare service domain, there were questions asked such as, in the last month, what was your level of need for help with having opportunities to discuss your concerns with doctors? For the psychological and emotional domain, it was about managing concerns about the cancer coming back. Whereas for work and social, it was about getting more support from your family. And then for information needs, it was about accessing information that's easy to understand. And you can see here across in this bar chart that there are similar unmet supportive care needs across the 4 groups. So here across the Arabic, Chinese, Vietnamese and English speaking groups, they all had quite high unmet needs related to the health service, as well as for their psychological and emotional needs. This was followed by informational needs, and lastly, work and social. So you can suggest that with their work and social needs, these are largely met. So they're able to talk with their employees, they're able to talk with their friends if they needed anything practically. However, with health services and the supports that they might need and getting the information and that sort of thing, across all groups, they had higher unmet needs. And this was the same with the psychological and emotional needs. And so we also looked at how many supportive care needs that people had. And so we looked at the percentage of carers with no unmet supportive care needs, less than 10, or more than 10 unmet supportive care needs. And you can see here that there's some differences across the different cultural groups. So for Arabic speaking caregivers, over 2/3 of the group had more than 10 supportive care needs. And so this was quite high in comparison with the other groups. With over 20% had less than 10 supportive care needs, with 4.5% having no supportive care needs. By contrast, you can see here for the Chinese speaking caregiver group that just over 50% had more than 10 unmet supportive care needs, while over 1/3 had less than 10 supportive care needs, but around 15% had no unmet supportive care needs at all. And you can see here with the Vietnamese and English groups, they were quite similar. So with the largest group, about 50% having less than 10 unmet supportive care needs, while around 45% had more than 10 supportive care needs. But you can see here that the Arabic group had there's a larger proportion with higher unmet needs and a smaller proportion with no needs compared to a few of the other groups. And finally, in looking at what were the top 4 unmet supportive care needs across the 4 different cultural groups. And there were some similarities as well as some differences. So for example, across all groups, they rated obtaining the best medical care for their patient as a very high unmet need. And similarly, information about financial supports that are available to them was also a very high unmet need across all 4 groups. And reducing stress for the patient. And this is in terms of having supports and services that were available or that they could access to reduce stress for the patient was also a very high unmet need for all 4 CALD groups. But there are also some differences. So for example, for Chinese speaking and Vietnamese speaking caregivers, there was a focus on information about treatments, and that was a high unmet need for these 2 groups. And for English only speaking, as well as Vietnamese speaking caregivers, they had needs about addressing fears about deterioration. And by contrast, for the English only speaking caregiver group, they had high unmet needs related to obtaining adequate pain control. And so you can see there are some similarities and differences, but across all 4 CALD groups, you can see that for the Arabic speaking group, their top unmet needs were really related to emotional needs, so managing concerns about the cancer returning, as well as understanding the experience of the patient. and then followed by being able to reduce stress for the patient. So what can they do for the patient? By contrast, for the Chinese-speaking, Vietnamese-speaking, English-speaking groups, they really had a focus on health service. So getting the best services for the patient, followed by informational and emotional needs. And so in conclusion, just to wrap up what Carlene and I have shared, there's really a need for clinicians, researchers, patients, as well as caregivers to work together to achieve a better monitoring of supportive care needs, and really a commitment to making sure that people are informed about the cancer, about the treatments, as well as services and supports that are available to people. And there's also a need to match supports to people's cultural and language preferences. So what works for some specific cultures might not work for others. And there are different priorities, and it's important to identify what these are. And there's also an importance there's a need for better cultural sensitivity in communicating about cancer. And so it's working through how might the information be best presented to different cultural groups, and how might it be better received. And so there's also a need for more effective strategies to improve referral uptake, uptake of referrals to different supportive care services to improve the health and well-being for people with cancer and for their caregiver. And there's also a need to better understand family dynamics for people. So how important are families in making decisions about treatment, and who wants to receive this sort of information, or is it a joint decision? So I think it's sort of better understanding the family dynamics. And lastly, there's also a need to better understand the role of the caregiver following a diagnosis, and how they can be better supported by health services in terms of their psychological as well as emotional needs, as well as in the practical caregiving role. So that's it from me. Thank you.
Thank you so much, Dr. Carlene and Dr. Eva, for your presentation. I want to bring over Professor Vicky White for the Q&A session. Vicky, we've got some amazing questions from the audience that have come through during the registration. So I would love for you to facilitate this, and I'll jump in here or there, but yeah, please feel free to facilitate. Great.
Great. Thanks, Kawana. Great presentation, Eva and Carlene. Thanks for sharing that really fascinating insight into people's experiences. And certainly there seems to be a lot of work that can be done in the area to improve people from a CALD's background's experience of cancer care. One of the questions we have, it's a bit of a comment, but I wondered if you could provide some thoughts on it. There's a comment that someone said a patient's son wanted them, I think they might be an interpreter, not to mention cancer when they were translating the doctor's words, and the interpreter said that they refused to do that. But I wondered if you had any thoughts or any sort of data around that notion of people in the family wanting to keep the cancer a hidden diagnosis from patients. Has that come up in your research?
We haven't addressed that directly, although I think some of Eva's quotes touched upon that. And I think that there is a bit of a challenge there in relying on families to be interpreters or to be the go-between in discussions around cancer and prognosis and death and dying. And I think that's a challenge that certainly the health system advises against relying on family members to be that communicator, and says we should rely much more on formal interpreter services, and where medical conversations can be had in a very non-biased way. But having said that, there is a strong cultural preference for having families involved, and Eva may want to make a comment on that.
Yeah, absolutely. I think that's a great question. And I think studies have shown that for some cultures, some cultures adopt a very fatalistic view of chronic diseases such as cancer. And so particularly for the older generations, if they hear that they've been diagnosed with cancer, then they automatically think that that's a death sentence. And so they're not going to accept the treatment, that potentially life-saving treatment for them, even though we've had medical advances, and so they could still live a very long and full life. And so I think that might be where the son was coming from, with asking, asking the word cancer to not be used. However, I think with that sort of, I think that sort of points to the importance of having formal interpreters during the appointment sessions to make sure that that information is conveyed accurately. And so I think there's a lot of filtering of information that can go on with families who are interpreting. And so I think maybe sometimes there's a bit of cultural sensitivity around the word cancer, but then also there's also that need to present the information accurately as possible. So yeah, I can sort of appreciate that there's probably a bit of a challenge if you're an interpreter in that situation, that you would have to, I suppose, still disclose that the person was diagnosed with cancer.
And sorry, can I just pop in there, Vicky, to say that I think cultural training, cultural sensitivity in communication of health professionals, so that they understand sensitivities around discussions like cancer. And historically, that's applied across the board, but I think particular cultural groups may have greater sensitivities, and having health professionals recognise those sensitivities and deal with them in a sensible way is part of what we hope to achieve in the future.
And that's great, Carlene. There's another comment in the chat that says there's gentler ways of interpreting without saying the word cancer in the Arabic language. And I think that gets to that need for the cultural sensitivities to come out. I also think that Kumbana might have a question or a comment that relates to pretty much what Eva was talking about with that generational change.
Yeah, look, I just wanted to draw that out a bit more, both Eva and Carlene, just in relation to generational. So obviously, so you might not know, but my father had cancer in growing up. And so frankly, at the time, my mum had only been in Australia for about 4 to 5 years by the time he got diagnosed. And I guess if that happened right now for me, I would understand where to go. But is there, from your research, do you feel as if the older generation of the migrant groups you've researched, they're the ones that need more intense, I guess, support for cancer going forward? Or will there be a real generational change where less so, my generation will be fine navigating this issue?
I think age it's almost cohort. So there are people who were born 80 years ago who, regardless of which culture they're living in, the diagnosis of cancer meant death. You were diagnosed with cancer, you didn't even think that you would last 2-3 years. You thought this was a death sentence. But since the 50s, 60s, 70s, we've had vast improvements in treatments. And so for most cancers, people go on living way beyond their diagnosis. But the mindsets haven't changed together with this diagnosis, with our treatment. So as our treatments have improved, the way people think about cancer, particularly if they're not necessarily highly informed about these changes to a prognosis, still get trapped in that old way of thinking about cancer. So I think there is an age component to it, but I think there's also a cultural component, so that in certain countries, there's still some sensitivity about perhaps where the sort of resources and medical treatment resources are not as readily available, then a cancer diagnosis may be a much more life-threatening one than perhaps in Australia today. So I think we're in the unique position of being younger, more educated about cancer, and having available to us much better treatments. So yeah, I think that may explain some of the disjuncture between your experience and your father's experience.
And I think speaking with that as well, then there becomes almost the younger caregivers, especially if they're the children of people diagnosed with cancer, there's increased responsibility that they're the ones having to get the information and having to explain that information and the importance of treatment or different types of treatment and helping with that decision making. So I think it's important for the caregiver groups to have that support about knowing where to access the information they need, or being able to talk to people if they need to find more information about the diagnosis and the treatments.
Great. There's a couple more comments in the chat area around the difficulties some of the interpreters have in not getting to meet people until they're almost about to go into the doctor's rooms, and then they have a very rushed conversation about whether cancer gets mentioned or not, and that if the interpreter says that that they can't not mention cancer if the doctor says it, then it can create some hostility with the family members. So the need to sort of improve the interpreter service in lots of different ways seems to be coming out quite strongly. I suppose that's a comment, but Carlene's nodding her head.
Yeah, I think, Vicky, that's really important. It's kind of like, is the interpreter just a machine that goes in there and repeats back what the doctor, almost like a sort of subtitle for the doctor or the other medical professional, or are they someone who has a bit of an advocacy role? Now, I think at the moment, we're very much that sort of machine translation part, but the best communication will only occur when the patient can feel they can trust the interpreter. So trust is really critical in the communication pathway. So to the extent that the interpreter is involved in the communication between the health professional and the patient, there needs to be a sense of trust. And as the interpreter rightly pointed out, establishing trust just by walking in the door it's a difficult thing to do. So I think that's one of the sort of challenges that we probably haven't given much thought to before.
And can I say, I think there's probably also a need for, especially if interpreters are involved with the appointments, for perhaps longer appointment times, especially when the information is being presented twice. I think research from the University of Sydney has shown that appointment times are still the same whether or not you have an interpreter involved. And so I think you need, you do need that extra time to be able to interpret that information and to ask those questions and to get that information, especially if it's a new, if it's about a new diagnosis, and people do have those tensions when they're communicating information.
Great. And a couple of supportive comments coming through there, Carlene and Eva, to what you've just said. I'm going to change track a little bit and just come up with another question that's come through. And it's about what you think the biggest unmet need might be for patients. So across all CALD groups, if you could wave your magic wand, Carlene, what would you like to see that would sort of address a key unmet need for all of the CALD communities?
Thanks, Vicky. Yeah, I think it's pretty obvious what I'm saying, and that is really this timely, accessible, relevant information, so that the patient, the CALD patient, is just as able to get the information they need when they need it, and in a way that's accessible to them and understandable by them as the non-CALD person. And if I can have a second bite at the cherry, I would say provision of that emotional support, that help with the fear, that help with the anxiety, that help with what's going to happen next, the need to maintain a positive outlook. That applies regardless of what culture you come from. But getting that when English isn't the first language and when you're not so sure about cancer, that's a really difficult ask. And I think if we can provide that timely, accessible, relevant information together with saying, this is the emotional support we can provide you. We'll help you through this journey. We'll help you with your anxiety. We'll help you with your fear. We'll help you with your depression. Then I think we're doing a much better job at supporting CALD cancer patients.
Great. And Eva, the second part of it was related to what about the carers? What would you like to see happen there?
Yeah, sure. I think from our survey data, you could really see that caregivers had a lot of unmet needs based on supportive healthcare services. And so it's that support from health providers and clinicians about the information that they might need, the types of supports that they think that the patient needs. And so really having that, I suppose, being able to feel supported by various health providers in that particular role is quite important. But also, I think what was quite evident from the surveys was that they had a lot of unmet psychological and emotional needs. So it's about being able to enabling caregivers to access the supports and services that they might need to address these psychological and emotional needs that they might have as part of caregiving.
Great. Just a follow-up question from that. I think you both made mention of the need to sort of get people to provide people with the access to support services. And in your data, you showed that, you can refer people to support services, but there's a low uptake of those services. So what can you do, or how can we encourage people to start to take up the referrals to supportive care services?
Yeah, it's a really interesting challenge, Vicky. And I think that's one that all the sort of supportive care services are struggling with, even including places like cancer councils and any sort of provider of supportive care. And I think the really important thing is that we normalise use of supportive care. So we know with initiatives like Beyond Blue and so on, that we've normalised the notion that people have mental health challenges and it's okay to seek help for those. I think we need to move that message to the cancer survivor space and say, there's going to be ongoing psychological and emotional challenges. You're all going to experience them. There's services out there to support you through them. You don't have to struggle alone, and that you should be using these services where they're available. So it's normalising these and then tailoring them to the needs of different groups. So men may have different needs than women. Younger people have different supportive care challenges like sexuality, fertility, for example, than older people. So we need to make sure that we target and tailor our supportive care needs to meet the needs of unique groups as well as individual people.
Great. There's a comment, Carlene, and I know we're coming close to the 4 o'clock end of the thing, but it's around having, people who get a cancer diagnosis can get severe depression, and that can have quite a negative impact on survival and lots of other outcomes. So we just wondered, what's the best way to treat that sort of depression or the severe depression, and can that become a bigger issue for people than the actual cancer?
Oh, absolutely. And I think that's why identifying that early, that's why having those distress talks from the very beginning, and not just once, but throughout the journey, throughout from diagnosis through treatment, even into survivorship. Because for a lot of people, they can cope while they're dealing with the struggle of the cancer, but then once they go home and they don't have access to the doctors anymore, it all hits them like a ton of bricks. The depression sets in, they're scared about it coming back. Now, if someone's got significant depression, as opposed to lots of people have transient depression, and that they can get by those feelings of depression through a few useful sorts of strategies like mindfulness, doing a bit of mindfulness, perhaps doing a bit of physical activity is a really good strategy for dealing with things like fatigue and anxiety and depression. But if they've got significant ongoing depression, really seeking psychological help is key. And I mean, that's part of what the supportive care services provide, but it doesn't need to be that significant. People should be seeking help and dealing with depression, even where it is transient, developing strategies so they get that personal control back. And for me, the secret to success with a cancer diagnosis is maintaining some sense of control over your life, including control over your emotions. So that would be my observation.
Great, thanks, Carlene. We've got 3 minutes left. So, Kubana, do you want to ask another question, or?
Yeah, look, I'll just quickly jump in, and this is more if you had an absolute wish list, and this goes out to both yourself, Vicky, you can join in. Obviously, we have the federal election happening. What is it that you want to tell the future health minister? Like, what should they be focusing in? What would be your key ask? You
can imagine what I would be saying. That we need to embed supportive care services within cancer services as something that the government pays for. It's not something that's paid for through donations or through NGOs. It is a fundamental service that people are entitled to, just like they are for mental health services at any point in time. I'm not just talking here about emotional psychological support. There's practical support that people need. There's a whole range of support that they need. Information support, but this needs to be part of the government's responsibility to provide that. So that would be my take-home message to the people at the next election.
And Eva?
Yep, I agree with everything that Carlene has said. I would suggest continuing with the Australian government initiatives for caregivers. So, for example, with the Carers Gateway, but as Carlene had said, improving supportive care services and embedding that within the health service, but also targeting caregivers and making information that's available and tailored for them, but also tailored for CALD communities and identifying what are their specific needs. So it sounds like Arabic people have sort of more emotional needs, while other groups have sort of different health service needs. So making sure that all of these needs are targeted and tailored, that's accessible and appealing to different cultural communities.
And
Vicky, why don't you round us out?
Well, I agree with everything that's just been said. And so what that means is that we need more money. And really, we need a significant investment from the governments to enable all the things that we've just spoken about to be embedded in the healthcare service. And that would include money for allowing permanent interpreters to be working with cancer patients and families. So they're not just meeting people at the point of entry into a doctor's room, but they can start to develop those relationships and learn how to talk with patients, but also doing the cultural sensitivity training and embed that across health services, and making sure that's not just a one-off, but something that keeps on being talked about as we go through health.
Well, thank you, everyone. That was such a delightful webinar. So before we wrap up this webinar, if you'd like to learn more about research, community engagement, cold communication, or to speak to us about a project of your own, you can reach out via our website, loteagency.com.au, or email info@loteagency.com.au. Finally, a big thank you to Carly, Eva, and Vicky from Austin Health for sharing the results of this important study. We'll make this webinar available on our social media channels. And if you have any further questions or comments for the LOTE Agency or Austin Health, please get in touch. So thank you for joining us. And if you're celebrating Easter, we wish you an enjoyable and safe weekend away. Thank you, everyone.
Thank you.
Thank you.